My research is about involving patients at the Morbidity and Mortality meeting. And this research has been done at the Department of Obstetrics and Gynecology, specifically in the field of gynecologic oncology. My background is actually, I'm a social scientist, I'm a medical anthropologist. So I will give you an explanation of the research I conducted, which considers also a very social aspect of this meeting with the people involved. So first of all, the Morbidity and Mortality meeting, I'm sure most of you are well aware of what this is. And so the goal is to learn from adverse events, mostly also with registrars or fellow, and to get to the core of what happened, why it happened, and how we can improve healthcare for the future. However, this meeting has been organized in many different ways. As you can imagine, so some departments, surgical departments, they will organize it weekly, some monthly, some discuss all adverse events that occurred in the past week or month, and others will only discuss one case. That is the case for us. We do it monthly and we discuss just one adverse event. But there's also been a lot of criticism on this meeting because sometimes learning points do not have the value that it needs to really improve healthcare. And also it has been a difficulty to implement all the learning points in practice, which I will continue on. In our case, we were focused on how to achieve more patient-centered care. Patient-centered care is one of the 6 dimensions of quality of care. So we believe that we can improve care by involving patients more, and also the solutions and the learning points that come from the meetings should also be considering the patient and their overall wellness and experiences. Because positive patient experience, of course, increase the quality of healthcare. And different research found that the perspective of patients is new and different on the causes of adverse events, so they can actually help in surgical morbidity mortality meetings to make sure these learning points are considering also communication, for example, or collaboration between healthcare professionals and or the patient. So we believe that patient-centered care can increase the quality of the meeting. So we had to change a few things in our morbidity and mortality meeting. As you can see, we made it also more inclusive, as to say. So we invited also nurses from the outpatient clinic and ward. Also consultants from other departments were involved. You can think of urologists or general surgeons that were involved in during the surgery. And we invited also the case manager. We have a case manager that coordinates the care of cancer patients within our department, and also connected to other departments where they need care. And of course, we added an extra chair for the patient, who is welcome to bring also a companion. You can think of a family, a relative, or a partner, or a friend even. And we had questions before whether or not patients were allowed to bring a lawyer, or, because these cases are very sensitive. In our instance, we never experienced a patient with this request, but we would really consider this also as an option to bring clarity and transparency. However, of course, this needs to be discussed and carefully handled. So practically, this changed a lot in our meeting. So when a patient joins the morbidity and mortality meeting, we always make sure that the patient has time before and after the meeting with the case manager. Sometimes they still have questions, or sometimes they need to prepare also for the meeting. And during the meeting, at the start of each morbidity and mortality meeting, the one who leads the meeting will always state the goal. So there is no blame and shame. We want to get a better understanding of what happened, and in the end we want to improve care for the future of other patients, and that should be the mindset of everybody involved when discussing adverse events. There's also time reserved to ask questions, also for the patient, to give them a platform and for them to explain the impact it has had, the adverse event. And of course, we also adjusted the language. So it had to be more comprehensible for patients to follow the discussions. So we had 3 different ways we researched this topic. First, we did a general evaluation, which is more explorative to understand the experiences of patients and professionals. We also looked from a more social scientific perspective, because participation of patients is not an easy task. And in many different areas in the hospital, we see that involving patients is not just inviting them to take a seat at the table, but you have to adjust in many other ways. So we considered it as a learning process. And in the end, we also wanted to see how we can improve the implementation of meeting outcomes into daily practice. So these 3 topics I will show you. So first, the evaluation of the experiences. These were the first 8 meetings where patients were involved. I did semi-structured interviews with professionals and patients. And we also did an analysis suitable for qualitative data. And that is a thematic analysis and grounded theory. So in total, 8 patients joined, because we do 1 meeting where 1 patient is involved and 1 adverse event is discussed. And we take 1 hour, which is quite a lot of time, but it also means that we go in depth. And usually one of the registrars will give an overall presentation also of the literature concerning the adverse event. The patients that were involved in the research were between the ages of 44 and 80 years old. And all of the surgical complications were due to oncological care, surgical care. 2 patients came alone without a family or a partner, and the others always brought a companion. And we interviewed 17 healthcare providers, which were very broad. As I mentioned before, also other consultants from other departments. So this is quite a lot of information, but what I want to show you here is that this is just a selection of 5 different morbidity and mortality meetings, and you can see that the adverse events were very broad. So we discussed an ileus, blood loss, but also urethra reimplantation, which was a very, a major complication. To zoom in on one of the patients, I spoke with her quite intensely, and she had a wound abscess because the wound got infected, but her urethra was cut. And she was very scared of what happened, because it happened at home, and she was rushed to the hospital, and she had to have a second surgery, and they reimplanted the urethra. And she had to take a lot of antibiotics. It was quite an intense journey for her. However, we were very satisfied that she came to our morbidity and mortality meeting to discuss what happened. This I will just discuss briefly. I think the shared teams are most important. This is after the analysis of the interviews. Well, you see that healthcare professionals focus a lot on the quality of the meeting, where patients focus on trust and safety. But the shared teams were the same. Open communication is important, adjusting language, the element of learning, and that it had a personal impact for both. A short quote of a patient. The patient also realizes that it's a learning process for all parties involved. And the patient saw more during the meeting that also the consultant was quite affected by the adverse event, and things did not work out as she has hoped. For healthcare professionals, it was sometimes difficult to see that, are we doing the morbidity and mortality meeting for the patient, or are we doing it to improve healthcare? And they had to balance it, because they did not want the patient to misunderstand information. So it took quite some time to really be comfortable and discuss everything. However, luckily, we found that the learning points were improved when the patient joined. This is just one example of the patient I just discussed who had a reimplantation of the urethra and a wound abscess. We took steps to improve the antibiotic policy and wound care, better transfer to home care. And also in the future, we will provide patients with tailored alarm signals, because the patient was not aware of what was happening before, while her wound was infected. So she called too late. So everybody was positively surprised. The involvement, the emotional processing for both parties. There were more diverse learning points, and actually the preparation of the meeting was a lot better. That is also connected to the multidisciplinary element, because we always invite everybody that is involved, also from other departments, and also, of course, the voice of the patient was part of the meeting. This is in line with that. I want to take you to just shortly to the COVID-19 pandemic, because we started our research in 2018, and then in 2020, COVID also took a big hit here in the Netherlands. But we wanted to continue to organize morbidity and mortality meetings where patients could join. So we decided to do it via video conference, and we did a pilot. We were very happy to also see similar results. However, the experienced healthcare professionals that have been doing this for quite some time, they missed nonverbal communication. So they could not really read body language or see every facial expression. We did organize a bigger screen so we could see the patient bigger while discussing the adverse event and learning points. But still, it was not enough. And also for the patient, they had one screen, and usually the healthcare professionals were a bit small in the screen. So that is something to work on. But we were very happy and positively surprised yet again that also this was a possibility. And we now also offer patients to join via the video conference or in real life if it's possible. As I told in the beginning, we also looked at this process as a learning process. So we decided to take the interviews we did in 2018 and look at them again and connect them with observations that I did. So I attended over 20 meetings where patients were involved, and I tried to look at what the differences were and what type of transformations healthcare professionals went through to be able to make sure that the patient could participate during the discussions of the morbidity and mortality meeting. Here's a table. I hope it's clear. I see it's quite small now. Below you can see the number of times a healthcare professional attended the morbidity and mortality meeting. And on the right, I made a square around the Department of Gynecological Oncology, because it's very significant that this group of people, of course, attended a lot more morbidity and mortality meetings than others, 4 to 17 times. So the group of people that attended around 17 times, they really had a lot of experience. And the people that attended for the first time, the consultants from other departments, or maybe a registrar that just came one time, or a nurse, they stepped into an environment with experienced professionals who were able to discuss adverse events in front and with the patient and be open about it. We found that this is very crucial now in the continuation of inviting patients at morbidity and mortality meetings, because a lot of other surgical departments are still kind of skeptical whether or not it would enhance their meeting, if they can reach enough learning points. So we found that we are even more obligated to invite other departments also to join our meeting, so they can experience what it is when you are there with an experienced group of people that are capable of being open and discuss things with the patient. So from this aspect, we found out that it takes time. A learning environment with experienced professionals supports unexperienced professionals during the MNM, yes, especially when it's still kind of exciting and they're not sure how the patient will react. Maybe they feel they have certain emotions about what happened. So that is very important. And also the step of changing these assumptions and underlying beliefs. We really want to motivate people that it is possible. So in the final piece of our research that I want to take you in is that we also try to improve the implementation of meeting outcomes into daily practice. This is an overview of time. So in 2016, we started with the morbidity and mortality meeting, which is our first improvement step, part 1, involving the patients. We did that for a few years. And then the second improvement step was to incorporate a cyclical workflow. So we created an action list, a check in the following meetings, so the PDCA cycle. And in the research, we also did interviews, which also helped in reflecting on what they learned and how they can implement these learning points in daily practice. I included the video conference during COVID-19 because it was around the same time that we started with these things. So what we did, we developed an intervention, and this intervention included a PDA cycle with a few tools. And the research involved participatory action research. For those of you who do not know what it is, it involves interviews and observations, but it also means that the people I study are part of the research, and me as a researcher was also part of what happened. So I was part in each meeting. Maybe the next slide would make it more clarifying. Yeah, so we developed a table that include the PDA cycle, and we used that every meeting. And I was the one who kept the outcome of the meeting. We assigned a professional to each task. We planned how we can get to the result. We set deadlines. We made a moment of a check, which is usually the next M&M meeting. And then, of course, if there were additional measures or actions. So I was the one keeping track of this table, and I was also the one, sending people an email if there was a task they still did not do, or if they needed any help performing the task. So I could really understand the struggles of some of the professionals to continue, to implement these actions and learning points in daily practice. So the personal follow-up, which is number 2, was actually an important part of the intervention. A lot of times tools are developed and we present them to professionals, but it's not easy to take something and use it automatically in a perfect way. And the personal follow-up was really important, so people were reminded and they understood what needed to be done. And also they got help if they needed any help to perform the task or action. And the assignment of professional was also really important. This was a circle. Of course, next to it, I also did interviews. These balloons are the main teams that I found, and everything is actually based in the organizational culture where people work in. So teamwork was really important, that they have an environment that's supportive, but also that they know what the different tasks are of their colleagues. So they know who to ask. Communication to mobilize employees, which of course important. People will not do automatically what they tell you to do. It's important to motivate people and to communicate in a positive way. Motivation, which I'll go into in the next bit, because the motivational drivers are really important, and also that you understand why people have resistance, whether or not to follow up on actions. There need to be commitment, ownership. This is usually related to the weekly tasks of a consultant. So if somebody is responsible for the operating area, they will get all the tasks related to that, and they will not get another task, which is related to educating new students, for example. And of course, it requires skills. You need to be able to collaborate, because a lot of actions or improvement efforts, they need to be dealt with together. So we looked at motivational drivers also, resistance, and we want to give some general advice. I just want to give one example. The motivational driver, as I just said, is having a sense of ownership, which is really important because everybody's busy. So it should make sense that they are the one performing the task. The resistance is especially this one. Consultants or professionals got very resistant when they were made responsible for an action without giving consent. So you have a meeting, you divide all the tasks, and you give random to some people some tasks. So this happens a lot, of course. Sometimes it's necessary, but most of the time you will have more motivated colleagues when you handle this with care. So you explain the assigned action via phone or call or a more elaborate email. And also explain clearly why it's someone's role and responsibility to perform the task, not just by giving the task. So in conclusion, including a PDCA cycle at the M&M meeting promotes reflection and behavioral change. Assigning tasks to a professional with reminders improve implementation of learning points. And this is also the personal reminders that I spoke of. And an organizational culture. We need to promote collaboration, division of work tasks, and also creativity. If you get a task and you're not able to be creative in how you're going to perform the task, it's really difficult to get started and be motivated. We also developed a guide. If you have any more questions about this, we have a structured guide in how you can set up a meeting where you can involve patients. So if anybody's interested, we have something that will help. We also share it with our colleagues in the field. Well, my message in the end is just give it a try. It's very important to build a relationship of trust and safety before you start. It really improved our M&M meeting. And it's really important to have support from the whole team, especially from leading figures. We had a head of the department that was here really positive about this new approach in M&M meetings. So that really helps. And of course, to have openness to new perspectives. It increased patient-centeredness, but it also increased thinking out of the box and improving, improving the M&M meeting. I hope this was all clear. This was my talk.